It's critically important that we bring a health equity lens to everything that we do in cystic fibrosis. Back in 1938, Dr. Dorothy Anderson was the very first person to describe cystic fibrosis as a clinical entity. She actually described in the cases that she talked about a child who was Black and a child who was Hispanic. But unfortunately, those people were invisible to those who wrote the textbooks about cystic fibrosis. So it has been described repeatedly as a disease that occurs in white people. People who are Black, brown, they were left out of diagnosis, out of treatment and care for many, many years. So it's led to later diagnosis, which means people don't get care as early as they should. They are more likely to have severe infections and end up in the hospital a lot more, and they also are less likely to survive as long. These issues are built into the system. We have to be very intentional about knowing and acknowledging these differences because we know that there are preventable causes to poor outcomes that we're seeing.
I grew up in foster care from, I would say, the age of 3 until the time that I aged out at around 19 years old. I had all the symptoms and signs of having cystic fibrosis since I was an infant. All throughout my time in foster care, none of my medical needs were ever addressed. To tell you the truth, I never even had a physical before. So the only time I seen a doctor was in the emergency room when something critical happened. And each time that I would go, they would just tell me that I had chronic bronchitis or severe asthma, and they would just give me some antibiotics and an inhaler and just send me home. I was diagnosed at 24 years old. When he first told me, he looked at me and he said, it must be somebody up in heaven who really likes you because without any medication, without any treatment, you should have been dead by the time you turned 16. It's a miracle that you're here at 24. By the time I had my son at 32, I pretty much had a routine down as far as my CF was concerned. I remember when I gave birth and they put my son on my chest, he had this shallow breathing and I knew automatically something was wrong. So the next day, my son at the time that they were giving me the papers for discharge, he had threw up. And I remember saying to the nurse, could you give me the pediatrician? You know, my son just threw up and it's green. And so I remember her just taking a tissue and wiping it up and go, Mommy, it's not a problem. It's normal. Babies spit up all the time. And I said, but it was green. I remember seeing in her face how offended she was. So as I'm signing the paper, my son spits up again. This time I said, please go get the pediatrician. I need him to see this. So she goes to wipe it up again and I grab her arm and I said, no. Do not wipe it up. Get the pediatrician because I want him to see this. She goes, oh, Mommy, it's normal. Okay. So she goes and gets the pediatrician and he comes in. He sees the green sticky-like substance. And as soon as he sees it, he grabs my son out of my hands. He's running down the corridor with my baby in arms and come to find out that that green substance that my son was spitting up, that's a symptom of babies with CF. Had I went home and not advocated for my son, my baby wouldn't have made it.
Health equity occurs when everyone has fair and just opportunities to have optimal health outcomes. Health inequities lead to health disparities. There are health disparities in cystic fibrosis in diagnosis, care, clinical trials, and health outcomes. Health disparities are these poor outcomes that we're talking about that are preventable. For example, if someone is taught in medical school and throughout their career that a disease only occurs in people who are white, if a person who is Black or Hispanic presents to them with those symptoms, they don't have to be a racist to not diagnose that person correctly because the system led to their inappropriate knowledge about what CF is and who it can occur in. We have to look at the systems that lead to these health inequities and thus the health disparities that we see in cystic fibrosis. The difference between equity and equality is making sure people have what they actually need. So if you think about, for example, a family going to watch a baseball game and there's a 6-foot fence there. If you give them equal ways of seeing over the fence. The man didn't actually need the box in the first place. The woman might actually now be able to see over the fence, but the child still can't. That's an equal solution to the problem. An equitable solution would be to give everybody what they actually need to see over the fence. What we really want to achieve is justice. So in healthcare, what we need to do is remove those systemic barriers, poverty, racism, remove those, and then everyone can achieve optimal health outcomes. Health inequity in CF has also impacted research in multiple ways. So for example, with the CFTR modulators like Trikafta, the mutations that were tested were based on mostly people who were white. And that's huge because people who were in the trials got to continue on the medication for years before it was approved. And therefore, people of color were disproportionately excluded from having early access to these medications. And even now, because mutations in people of color are more likely to be rare or understudied, they are less likely to qualify for these life-changing medications.
When I think of health inequity, I think of how even though I had all the signs, all the symptoms of having CF, I wasn't diagnosed mainly because I was African American and Latina. Had I been tested based on my symptoms alone, then I would have been diagnosed a lot earlier.
It's really important that we bring the health equity lens to every aspect that we take care of in CF. So when we're thinking about cure, when we're thinking about care, and when we're thinking about community, we want all of our treatments, all of our approaches to engaging people to consider the entire population of people with CF. We don't want it to be one person of color on a committee of 50 people because that's not representative of what our greater population looks like. We need to bring those diverse perspectives to the table so that the person who is there is not thought of as the only voice on this one issue. We want every single person to be thinking about how can we make sure that outcomes in CF, that belonging in CF is something that every single person with CF feels.
I'm a part of a CF group that are people of color. And when you hear them say how sometimes they don't want to speak up for themselves because they don't want to come across as aggressive or as problematic. So sometimes they just won't say anything because they don't want that to affect the kind of services that they receive. That's unfortunate because if other members of the community are able to speak up for themselves and have other people speak up for them on the same issues, then they should be able to as well without any fear. And so I would hope that other patients and families can see themselves through my story and my experiences.
What gives me hope for the future is that we're actually having these conversations, actually working to identify the source of health inequity in CF means that we'll actually be able to start to make interventions that make optimal health outcomes a reality for every single person with CF.
I'm hopeful because I do see the changes happening. When I go to my CF center, I don't just see a sea of white people, from the doctor to the nurses. I see the attempt of involving people of color in the conversation and understanding the dynamics of people's backgrounds and people's way of living and how CF plays a part in that. I see that there's a desire to know and to make a difference.
We as a CF community need to acknowledge these health inequities and define the problem that led to these health disparities. We need to address these issues for all people with CF so everyone has a chance to have the best possible outcomes.